Welcome to our first international consortium meeting for alpha thalassemia major. Thank you all for joining us. I think we have guests from all around the world, and it's really exciting to see the interest in this area. So we're sort of building off the success of the January international meeting that we hosted that so many of you were kind enough to join and lend your expertise to. And now we're just trying to build an international consortium of experts in the many disciplines it takes to take care of a patient with alpha thalassemia major. So that includes those of you in hematology, maternal fetal medicine, genetics, fetal therapy, neonatology, our friends from patient advocacy groups, and even patients themselves. Our goal is to really improve the care of patients with alpha thalassemia both before and after birth. And we hope to do this specifically by building relationships. You know, a lot of collaboration is built on trust and friendship. And we hope that having these regular meetings will help us build some bridges across our institutions. We hope to share research findings as they become available. And developing consensus on best practices, for example, in utero transfusions, postnatal transfusions, postnatal stem cell transplantation regimens, et cetera. So the format that we have chosen is to have half of the meeting be a presentation and then the other half be a moderated discussion. And we were hoping that this can be especially a forum for young investigators to shine and get to meet international colleagues. So the future meetings are scheduled for August, where Mara Rosner from Johns Hopkins is going to present on in utero transfusion protocols. And Dr. Sharif Badami from Northwestern is going to present on the strategy for postnatal hematology care. We are recording this session. It will be available to view by invitation only from a box folder. So if you would like a link, please email Val Doherty, who's our extraordinary program manager who put together this entire conference. And I want to take some time to also acknowledge Valerie's work in coordinating this and a lot of the other aspects of our alpha thalassemia and precision medicine program. So Val will have the link to the box folder. So please email her, and you should be able to also use this as a resource for your colleagues who may not be able to attend this evening or morning as well. So, and then after the presentation, if you have questions or comments, you can use the chat box during the presentation, and I'll be monitoring those and using those to spark the discussion. And then during the discussion, you can also raise your hand using the reactions, the raise hand emoji. So it's a special privilege to invite Dr. Sandhya Kharbanda, my colleague here at UCSF, to kick off this series of meetings. Dr. Kharbanda is an associate professor of pediatrics here at UCSF, and she is the director of our bone marrow transplant program. Sandhya did her medical school in India and then pediatrics residency at SUNY in New York, and then went on to fellowship for Hem-Onc at Pittsburgh, and then bone marrow transplant in Minnesota. She was at UAB and Stanford prior to joining UCSF in 2017. And her work is really focused on hematopoietic stem cell transplantation for non-malignant diseases, particularly hemoglobinopathies. And her interest is in decreasing graft rejection using alternative donors or developing reduced toxicity approaches. And she's going to talk to us today about the postnatal bone marrow transplant approaches for thalassemia. Thanks, Sandhya.
Thank you so much, Tippy. First of all, it's really my honor to give this talk here today, and I really thank you for this opportunity, and also want to thank Val for helping with all the coordination. So I'm really excited to do this. Okay. So like Dr. McKenzie said, I will be talking about allogeneic hematopoietic cell transplantation for alpha thalassemia. And in the next 30 minutes or so, I thought that I would review some of the underlying principles of allogeneic transplant in thalassemias. And as you all know, the experience in alpha thalassemia major is quite limited. And most of our experience in transplantation is in a very closely related disorder, beta thalassemia major. But for sure, we can learn lessons from what we have seen in patients undergoing transplant in beta thalassemia major. So I'll start by showing some of that experience and then review what we have experienced in alpha thalassemia with respect to transplant. And then get more into our current approach at UCSF for transplanting these patients and the next steps in the field. So as you know, the main idea behind an allogeneic transplant is replacement of patient hematopoietic stem cells with healthy donor hematopoietic stem cells. And this relies upon availability of finding a suitable HLA-matched donor. It's really important that the patients getting transplant get prepared or conditioned with a conditioning regimen. And this is critical because in order to perform a transplant, one needs to make space in the patient's bone marrow. And that's called myeloablation. That's done to kill off hematopoietic stem cells in the patient's bone marrow space. And immunosuppression, which is to kill patient's immune system. And this is done in order to prevent rejection. So myeloablation and immunosuppression are two key elements of a conditioning regimen or preparative regimen that are given in the days prior to transplantation. All the currently available myeloablative agents belong to a class of chemotherapy known as alkylators. And in the thalassemia world, busulfan is a primary alkylator that is used for transplantation. So starting out with the current outcomes of allogeneic transplantation in beta thalassemia. So I'll show a couple of large registry studies that have been published in the recent years. This first paper was published in 2016 from the European Blood and Marrow Transplant Registry in about 1,500, 1,500 patients. And on the left side here, you see the overall survival and event-free survival. And these were 88 and 81% respectively. When they stratified their results based on the type of donors and the ages of the patients, they found significant differences. And it was found that patients who received matched sibling donor transplants, as abbreviated here with MSD, the survival, both overall and event-free survival, were the best. They were quite comparable with other matched family donors, but poorer with mismatched family donors and unrelated donors. And then stratifying by age, the younger the patient, the better the outcome. So patients who were younger than 2 had the best overall and event-free survival, and the older patients had poorer survival. An important point to mention here that the predominant conditioning regimen used during this 10-year period and described in this paper was busulfan based. Another big registry study, this was mostly from the United States and Asia, again found similar results and also similar trends with respect to the type of donor and ages of patients. So on the left is overall survival, on the right side is disease-free survival. With respect to donor choice, patients who received matched related donors and as well as matched unrelated donors They had the best survival, overall survival, and matched sibling donor patients had best disease-free survival. The patients who got mismatch related donors had the poorest outcomes of all. And then with respect to age, patients younger than 7 had the best outcomes, and patients older than 15 had the worst outcomes, as shown here. So again, similar theme that younger the patient, the better the outcome, and the better matched a donor, the better the outcome. In the recent years, it's not moving. Okay, sorry about that. In the recent years, as you all know, there has been a lot of interest in exploring other choices, donor choices for transplantation in thalassemias, in particular haploidentical donors. And the main reason for this is that majority of patients do not have a matched sibling donor or even a fully matched unrelated donor available. And there are primarily 2 strategies that have been trialed for haploidentical donor transplant. So haploidentical means half matched or about half matched, and these are usually family donors, either siblings or parents. So one approach of haploidentical transplant is an alpha beta T cell depleted approach that was reported from the group in Italy on thalassemia patients. It's a small report as opposed to the large registry studies that I just showed. Unfortunately, the authors reported a significant incidence of graft failure of 14%. And the overall and disease-free survival were not as good as what was seen with matched sibling donors or fully matched unrelated donors. Also, these patients were preconditioned with azathioprine and hydroxyurea. They were also given fludarabine to immunosuppress, and then conditioned with a busulfan-based regimen along with thiotepa, which is also an alkylator, and anti-thymocyte globulin. Another strategy to do haploidentical transplant is giving a T-replete product. So T cells are not depleted from the graft, but the patients are given T-replete product, but then given post-transplant cyclophosphamide for graft versus host disease prophylaxis, and additional immunosuppression is also given for non-malignant disease patients. So in this study published by Anurathapan in BBMT, they're from Thailand, they reported about 95% survival in about 80 patients or so. But again, important to mention here that these patients were preconditioned quite heavily with azathioprine and hydroxyurea. They received pre-transplant immunosuppression with 2 cycles of fludarabine and dexamethasone, also received bortezomib, and then were conditioned with busulfan and fludarabine and anti-thymocyte globulin. But with this approach, they were able to show very good results. An important question that comes up when we do transplantation for non-malignant disorders, and in particular hemoglobinopathies, is that what is the threshold chimerism that's needed? The word chimerism is derived from Greek mythology, and in the transplant context, it indicates the % donor cells that are present in the patient after transplant. So not much is known in the thalassemia literature. There are some studies that have been done in sickle cell disease, which is another hemoglobinopathy, as you all know. It's thought that 20 to 25% myeloid chimerism, myeloid cells being the main cells lineage that gives rise to the red blood cells. So these are the cells of interest for hemoglobinopathies. So in sickle cell disease, a threshold chimerism of 20 to 25% has been described. In thalassemia, Lucarelli's group published this paper in 2008, and they reported that the relationship between mixed chimerism and rejection, and they found that patients who had more than 25% residual host cells had higher risk of rejection. However, a big limitation of their study was that they did not analyze myeloid cell chimerism. But in a future study, they dive deeper into this question of lineage-specific chimerism. And they found that in 4 patients, 3 with beta thalassemia, 1 with sickle cell disease, at much later time points after transplant, even though the percent donor nucleated cells in peripheral blood and bone marrow were as low as 15%, and another patient with in the 40s to 50%, the percent donors, red blood cells in peripheral blood was 70 to 100%. And this was remarkable since it showed that not 100% chimerism would be needed, and even low levels of myeloid chimerism might be sufficient. And in our own experience, where we have seen similar results, in one of our patients, I just show this as an example, a 2.5-year-old boy with beta thalassemia who underwent a matched unrelated donor transplant with a busulfan-based conditioning, ended up with mixed myeloid chimerism. So on the left side, you see the chimerism graph. CD1415 is shown in blue line, and this reflects myeloid chimerism. So this is the lineage of interest. CD19 is the B cell chimerism, CD3 is the T cell chimerism, and PD is peripheral blood. This is the whole blood chimerism. These are the time points after transplant. So this is the post-transplant day, and these are the percent donor cells. So as you can see here, if I can bring your attention to the blue line here showing the myeloid chimerism, the patient started out with good chimerism of 100%, but by day 100 had already started to drop his myeloid chimerism, and it continued to drop, plateaued at around 50s towards the end of this first year, and then sometime in the second year after transplant had dropped to as low as 25%. But this patient continued to remain transfusion independent with normal hemoglobins, and that's still the case. He came in I wanted to show this as well, to show the curative effect of transplant, not just on transfusion independence, but this patient who was heavily iron overloaded with ferritins over 4,000 prior to coming to transplant, which was somewhere here, had continuing decline of his ferritin and now has normal ferritin level and no longer has iron overload. So to summarize what we have learned from transplant in beta thalassemias, the best results are obtained using matched sibling donors with greater than 90% survival. Unfortunately, though, only 20% patients have availability of this kind of donor. It's encouraging that almost comparable results are obtained using unrelated donors, and there have been some recent successes with haploidentical donors, though in very small studies. Overall, alternative donors do have risks, and these risks are primarily rejection, graft versus host disease, and opportunistic infections. We have also learned that hematopoietic cell transplant should be performed as early as possible, ideally before the age of 7, to decrease the risk of treatment-related mortality, which is thought to be secondary to iron overload and organ damage. And while threshold myeloid chimerism is not clearly known, we think that 20 to 25% myeloid cells donor-derived might be sufficient, and myeloablative approach has remained the standard of care. A concern is that with the use of chemotherapy, especially alkylator-based like busulfan, there are acute and late effects. And the ones that there are the serious side effects can be hepatic veno-occlusive disease, acute and late lung toxicity, risk of developing secondary malignancies, and infertility. And these are significant risks. So moving on to transplantation for alpha thalassemia. What do we know? What's the experience been? So since the first report in the late 90s of a baby who was transplanted for alpha thalassemia, several other reports were published, but the experience still remains limited. And about 10 patients have been described in the literature. And I'm going to summarize these in the next 2 slides for you and just review the results. So in this table here, you see the age of the patients, their history of their intrauterine transfusions, birth histories, iron status before coming to transplant, the stem cell donor source, the conditioning regimen that was employed with toxicities, outcomes, and neurocognitive deficits before and after transplant. So as you can see, most of these children are very young, 2 years old or less than 2. This child is a little bit older here. These are arranged in a chronological order. So the first 2 patients described in the literature did not receive IUTs. These are their birth histories. Most patients in this table that were described had moderate to severe hemosiderosis. The first 4 patients received matched sibling donor hematopoietic stem cells. The second one received sibling cord, that was 5 out of 6 matched. And as you can see, most of these patients received a busulfan-based conditioning regimen, except for this third patient who received total body irradiation, which is no longer used because of its side effects, especially in young children undergoing transplant. These are the outcomes. So the first child had mixed chimerism, 75 to 90%. They did not describe lineage specificity, and my guess is that in that era, they were not checking for lineage specific chimerism. This patient did well and became transfusion independent. This child did have neurocognitive deficits that improved after transplant. The second patient, again, did well and is transfusion independent. Some patients developed toxicities like veno-occlusive disease. What I want to point out in this table are these 2 patients here who received a reduced intensity conditioning regimen, or RIC, using low-dose busulfan and TLI, total lymphoid irradiation. Both these patients, one who received a matched sibling donor transplant and one who received an unrelated cord blood transplant, ended up having graft failure. This patient just continued on transfusions afterwards. And the second child received a second transplant with unrelated peripheral blood stem cells, again with the same low-dose busulfan, but this time the investigators, they substituted a total lymphoid irradiation with a low dose of total body irradiation. And the patient engrafted, but developed a complication called post-transplant lymphoproliferative disease. This patient also had neurocognitive deficits before transplant, and after transplant, they reported was continuing to be on special ed. And then these are the other 4 patients who have been reported in the literature. These are, of course, the oldest, and these 2 were siblings. This child, unfortunately, did not survive, had not received IUTs, received a mismatched unrelated donor transplant, and died of treatment-related mortality. The younger sibling who came in with good iron control and had received IUT ended up doing well and is transfusion independent. Unfortunately, the details of this child's transplant were not in the paper. And then these are the other 2 patients who underwent transplant. I want to bring your attention to this child, the 5-month-old, who received a fully matched unrelated donor marrow transplant using a busulfan-based regimen. And if you look at the chimerism, CD33 here indicates myeloid chimerism in the bone marrow. This patient had 15 to 20% myeloid chimerism only. So again, another example of low level of myeloid chimerism being sufficient to render a curative benefit. this patient became transfusion independent. Unfortunately, did have severe veno-occlusive disease, but recovered from that. So these are the experiences published on alpha thalassemia. As you all know, alpha thalassemia is a fatal disease if untreated, and because of the severity of the disease and fetal hypoxia and hydrops, this is a prime candidate for intrauterine hematopoietic cell transplant. And there are 4 reports in the literature of intrauterine transplant for alpha thalassemia major that I have listed here for you. So not many details are available for some of these, but the gestational ages at which these transplants were performed were between 13 weeks and 31 weeks. 2 of these, the second and the fourth, received IUTs, and they also received more than one hematopoietic cell infusion in the intrauterine period. The donor stem cell source was fetal liver cells in the second fetus, was maternal bone marrow in the first, and paternal bone marrow in the third and the fourth fetuses here. Unfortunately, these are the cell doses listed. Unfortunately, none of these patients had engraftment. The fourth patient here underwent a postnatal hematopoietic cell transplant at 3 months of age without any conditioning, and this patient did not engraft. But in this patient, the authors, they published in their publication, they showed that they reported that there was evidence of alpha globin in the baby's cord blood when the baby was born, and in their bone marrow at 3 months of age. And in a one-way MLR, mixed lymphocyte reaction assay, they found almost no response to paternal cells. This is the recipient, these are the responders on the x-axis. This is the control, this is dad cells, and these are mom cells. So they established an important concept that immune tolerance is possible, and that provides a rationale for postnatal hematopoietic cell transplant in these patients. Along those lines, as you all know, we do have a trial here. Dr. McKenzie is the PI of this intrauterine hematopoietic cell transplant study being done at USCF. And the idea here is to harness fetal tolerance. And our hypothesis is that since the fetus learns to tolerate foreign cells or proteins it sees during development and is seeing mom cells, it would be a good idea to use maternal cells for transplantation. And then if the fetus becomes tolerant, then after birth, they could get additional maternal cells without much immunosuppression, if any, and lead to a curative benefit. So this is the trial. The maternal bone marrow is harvested and given CD34 cells selected and given infused into the fetus via an umbilical vein with 1% T cells given as add-back. This is performed at 18 to 26 weeks of gestation and done at a time when the fetus is getting an in utero transfusion, and then they continue to get IUTs every 3 weeks. So this shows the harvest being done in the operating room. This is Dr. Dvorak, my division chief, Dr. McKenzie, they're collecting the marrow. Then it is put through the Clinimax Milteni column, and CD34 positive cells are selected. And with a T cell add back, and after meeting all the release criteria like endotoxin are infused into the baby via the umbilical vein. So far, this trial is accruing, and so far we have enrolled 3 patients. 2 presented with hydrops, 1 with pre-hydrops that improved with in utero transfusions. This was our harvest yield. We have had no safety issues with bone marrow harvest or preterm labor. Hydrops is resolved. And they've had short NICU stay for 2 babies. The 3rd baby was just born yesterday, so it's 1 day old today. And in the first 2 patients, we have seen low levels of engraftment, and in 1 patient, there was tolerance to maternal antigens C. So what is our approach at UCSF for allogeneic transplant for thalassemias? So we do myeloablation that's busulfan-based and immunoablation that's fludarabine-based. The most important thing to mention here is that our chemotherapy dosing is pharmacokinetic model-based, this is given along with serotherapy with either anti-thymocyte globulin or alemtuzumab, which are also currently being studied for their pharmacokinetics. Our approach that we published last year has been to use, like I said, model-based dosing of busulfan and fludarabine along with serotherapy, which was modified after our previous protocol, where we used more of standard dosing of these agents with additional agents like clofarabine and thiotepa, and refined it to have more precisely dosed model-based dosing of these agents. There has been extensive work in the field of pharmacokinetics for conditioning agents at UCSF, and Dr. Long Boyle is the leader in this field. We recently published busulfan model-based dosing, particularly in non-malignant disease patients. And to draw your attention to the third group here, these are the hemoglobinopathy patients, where on the y-axis we have the busulfan cumulative area under the curve, and these ranged anywhere between 58 to 79. And then on the bottom graph here is the myeloid, CD14-15 myeloid chimerism. And all these patients had close to 100% myeloid chimerism, with the exception of this one. And this is the child whose graph I showed earlier, who had mixed chimerism. On the right-hand side, these are all the patients, and on the x-axis are the cumulative AUCs of busulfan, and these are the percent subjects in different exposure cohorts. And as you can see here, above 70 and above cumulative AUC, patients had myeloid chimerism of greater than 20%. Similarly, we've also been working on fludarabine pharmacokinetics, and this was a paper published looking at cumulative AUC of fludarabine, and an optimal cAUC of 15 to 19 was found. And more recently, Jaap Polen's group also looked at this and found an AUC reported that an AUC of 20 was associated with better outcomes. So with this pharmacokinetic dosing model-based approach, our survival from the prior years, when we used a more standard dosing approach, has improved significantly, approaching 100%. And in the hemoglobinopathy patients, we had 100% survival. So in terms of next steps, I showed you the slides on our current trial. So the patients who are enrolled on this trial, they get the in utero transfusions and in utero hematopoietic cell transplant. They continue to get every 3-week IUTs. And then we evaluate chimerisms for these babies when they are born and for the first year after birth. And if they have no chimerism, then we know that transplant was not effective. If they have greater than 10% chimerism, then we would consider it effective. The question is whether it would be sustained or not. And for patients with low chimerism, we would offer postnatal booster transplant with maternal cells. So the next steps towards this booster transplant, the first question is timing, and based on what's published and on the Hayward, based on the Hayward paper, as well as our experience, we think that the timing would be no later than 6 months of age and as early as 2 to 3 months of age, and could be even considered earlier. Stem cell source would be maternal hematopoietic stem cells that would be alpha beta T cell depleted. And with our myeloablation, the goal would be to get at least 20 to 25% myeloid chimerism. And our preferred approach is an antibody-based non-toxic approach versus standard busulfan-based. And I'll talk about that in the next couple of slides. As far as immunosuppression, assuming immune tolerance, we would require minimal to none of immunosuppressive agent, and we will probably be using serotherapy alone. So for the antibody-based approach, the antibody here is anti-c-Kit or JSP191. This is an antibody which is currently in trials for babies with severe combined immune deficiency. It works by blocking the binding of stem cell factor to the stem cell factor receptor, or CD117, or c-Kit, which is on the surface of stem cells. And this interaction between stem cell factor and CD117 is important for survival of the stem cell. So JSP191, by blocking the stem cell factor binding to 117, clears out these hematopoietic stem cells and empties the bone marrow niches, allowing the donor hematopoietic stem cells to engraft. This is really important, and the fundamental reason why we would consider this over a conventional busulfan-based approach. So using busulfan or conventional chemotherapy, not only do we get the desired effect, which is clearing off the patient's hematopoietic stem cells and making space in the marrow, but we get off-target effects because patients' other cells, which are healthy, also get damaged. And this tissue injury can lead to severe organ damage, and there's risk of also the risk of secondary cancers. As opposed to JSP191 or anti-c-Kit antibody, which is selective in targeting the stem cells while sparing patients' other healthy cells, so there's no off-target toxicity. So this makes it superior to the conventional approach, which is ridden with these risk of serious complications. More recently, from Dr. Shizuru's lab at Stanford, studies have shown that this approach of using anti-c-Kit antibody can be further optimized by combining it with a nucleoside 8 analog 5-azacitidine, which is a hypomethylating agent used for treatment of myelodysplastic syndrome clinically, and technically a type of chemotherapy, but has a much more favorable toxicity profile in the short term and minimal to no long-term side effects because it's not an alkylator. In this study that was presented at various international meetings, in a sickle murine model, it was found that combining anti-c-Kit antibody with azacitidine led to good myeloid chimerism that persisted late after transplant. So in conclusions, allogeneic hematopoietic cell transplant is curative for alpha thalassemia major. With good prenatal care, including timely diagnosis and intrauterine transfusions, fetuses with ATM survive without any major deficits. Regular transfusions is standard of care after birth, and allogeneic transplant should be considered as definitive therapy. IU-HCT is safe and feasible and allows for a unique opportunity to induce immune tolerance to donor antigens. And intrauterine hematopoietic cell transplant followed by early booster transplant from the same donor using a non-toxic regimen may offer not only a curative, but also a safe option to children with alpha thalassemia major. I think that's my last slide, and I'm happy to answer questions.
Sandhya, thank you. That was a fabulous overview.
Thank you.
Yeah, I really appreciate you putting so much thought into how can we optimize the postnatal transplantation regimens of particularly the patients who've gotten an in utero stem cell transplant, and the timing and the particular regimen that we use. I'm wondering if anybody has any specific questions to ask you or experiences to share with transplantation of alpha thal patients.
I don't have particular experience with thalassemia in this setting. This is Janelle. I'm a pharmacist that works very closely with Sandhya. But I've been in the, since the beginning, working on the Jasper 191 molecule, and we've recently even gotten a lot further with that molecule in terms of being able to really target the drug exposure that we want and predict the day that stem cell infusion might be optimal. So I'm really excited about that approach, in addition to using it with azacitidine, which has worked really well in infants with leukemia with relatively minimal toxicity to no toxicity. Acutely and long-term, we don't seem to see any sort of toxicity. So that looks like a very promising regimen compared to busulfan, which I feel like now we could do relatively safely in a very young child with what we know about the pharmacokinetics of busulfan, but nothing compared to something with anti-c-Kit and azacitidine.
Mm-hmm. Yeah, that's a great point. Anyone else want to weigh in? Ali, you just wrote in the chat. Do you want to just speak? Dr. Amid.
Hey, hi, this is Ali. Let me.
Hi.
Hi, I'm Ali. I'm from Vancouver. It was very exciting and informative. Thank you so much for this presentation. Something that we were talking with Dr. Mackenzie in the past and is fascinating for us, and we don't know what the answer is really, is that whether any degree of chimerism is acceptable in alpha thalassemia measure. You know, like the idea of the chimerism in beta thalassemia arises from the fact that the erythropoiesis is ineffective, meaning that it allows for the kind of a high proportion of the donor erythrocytes in the periphery, as you reviewed in the long-term data. You had 100% of the donor cells, even in the presence of the high chimerism in the bone marrow. In alpha thalassemia, though, there is no ineffective erythropoiesis. It's like the erythropoiesis is actually very, very high. And I don't think, or I don't know whether a chimerism would have the same effect in the beta thalassemia versus alpha thalassemia. So I wonder what's your take on that?
Yeah, that's a really good question. I think it's not, I agree with you that it's the ineffective erythropoiesis in thalassemia, and also probably in some in sickle cell disease that is probably playing a key role here. But it's not very clearly known if that's alone the factor for why you see that discrepancy, where even though the nucleated cell chimerism is low, you get you get a higher percentage of donor red blood cells. I think, at least from the published data, it's not, there is not much known in the limited alpha thalassemia data, except for that one or two case reports that I had summarized in the table, where there was this one baby who had 15 to 20% donor myeloid chimerism in their bone marrow and became transfusion independent and still continue to have some Bart's hemoglobin in their peripheral blood. So it's hard to extrapolate. I agree with you, but it seems that, at least from what's published, that there might be, because there were other patients in many case reports that I showed that were mixed chimeras, but the threshold percent is not really known. And I also think that even if we don't know what that threshold is going to be, using an approach like anti-c-KIT, we could, since it's safe, we could at least get some cells in, even if it's not curative in the first go, but save the baby from high-dose busulfan. But going to your question, yeah, I don't think it's clearly understood.
Thank you very much.
Yeah, thank you.
Any other comments or questions? It can be kind of broad. I don't know if there are people who've also taken care of alpha thal children, fetuses. Feel free to speak up. This is hard to build community over Zoom, but hopefully we can have an attempt over these quarterly meetings.
Hi, my name is Ant. I don't know if you can hear me. Can you hear me?
Yes, hi.
Yeah, hi. My name's Anthea Greenway. I'm a paediatric hematologist in Australia, so a long way away from you guys. No problem. I really enjoyed the last symposium. So this is related to an adult patient that we have in Melbourne, Australia, that we are treating, who has Bart's hydrops. Was actually born in the US and has moved to Australia several years ago. And she'd had sort of chronic transfusion and usual therapy throughout her life, a lot of problems with recurrent thrombosis and iron overload. And when she came to our centre, one of the adult haematologists began a program of red cell exchange. So we sort of have a mixed population, beta thalassemia, sickle cell, and some alpha thal. And so we commenced red cell exchange on the basis of, you know, improving her hemoglobin, reducing sort of Bart's hemoglobin, and suppressing her marrow and managing her iron overload was sort of the combined plan with that therapy. And she's done incredibly well, actually. And I just wondered if anyone had had similar experiences with other adult patients. So she's in her 20s. When she came to us, was not able to work, was on multiple anticoagulants because of all her thrombosis. And since we've put her on red cell exchange with the aim of keeping her hemoglobin at a reasonable level, low free plasma hemoglobin, low hemolytic markers, and we've managed to wean her anticoagulation. She hasn't had a thrombosis now for the last 4 years, and she's sort of back working at the gym and doing very well. So I just wondered if anyone else had that experience using other sort of modalities of transfusion therapy for adult patients. I know there's a small number worldwide with Bart's, but just whether anyone's had that experience for older patients.
Thank you for sharing. I will let an actual hematologist answer that. We have a registry, but a lot of our patients are much younger. Who wants to take that?
Hi, this is Ali again from Vancouver. I think our colleagues from Sick Kids in Toronto, they're also here. Dr. Kirby, I think you can join me. You have much more experience than me. But we have tried and used with effect exchange transfusion. Dr. Greenway, I wonder whether your patient was splenectomized.
Is a good question. I think she was splenectomized as a child. Yep, so many years ago. Yeah.
Yeah. So we have not splenectomized our patients, but we think a splenectomy is a poor choice for these patients because it actually allows hemoglobin H to be even more. Because the hemoglobin H is being picked up by the spleen, and then once you remove it, it actually increases your hemoglobin H even more and makes you even more functionally anemic. And we are doing studies finding out that these patients have an acquired protein S deficiency that plays into their thrombosis. So that is also interesting. But I think exchange transfusion is the way to go over chronic transfusion, which is, it would be kind of a hyper transfusion approach.
Yeah. So we've certainly moved away from splenectomy in the last 10 years, but you know, obviously a number of our older patients have been splenectomized sort of 20 years ago, I think, in part of their sort of early management before there was recognition of some of the longer term consequences of splenectomy. What do you think is the mechanism of the low protein S? That's interesting.
Oh, hypoxia. So because they have significant kind of ischemia because of the non-functional hemoglobin H. The hemoglobin is 100, but the hemoglobin is 60. So because of that hypoxia, they're proteinase deficient. These are just anecdotal patient, the N of 2, 3 patients, and really we are hypothesizing, but we have observed that they have low proteinase.
Yeah, it'd be interesting. I mean, I think, sorry,
this is Melanie. Hello, everyone. I just a comment about low protein. We've recognized this now in not just our alpha and beta thal patients, but our HS patients, parasitosis patients, and our sickle cell disease. So it seems like it's a feature of a chronic hemolytic condition too. I don't quite understand it. And our thrombosis, hemostasis thrombosis team, they have some theories, but we've also recognized this in parasitosis recently, several patients, and in sickle cell disease. And both of those also have increased thrombotic tendencies.
Thank you.
Dr. Greenway, just out of curiosity, was your patient a spontaneous survivor, or did she get in utero transfusions?
My recollection, I'd have to go back and have a look at the notes, but I think she was a spontaneous survivor. Yeah. So obviously some phenotype selection, as was the case when she was born 20 years ago, I suspect. Yeah.
Is anyone else right now actively taking care of a patient with alpha thalassemia? Oh, I see a raised hand. Yes, please. Here, you can unmute yourself.
Yes.
There you go. Thank you.
This is Adeyinka Falusi from Nigeria. I'm a hematologist in the area of genetics, human genetics. And thank you for inviting me. I did some work on alpha thalassemia. That's why I'm on the platform. But I want you to understand that in our parts of the world, we have alpha thal 2 is the main type of thalassemia we have, in which case we have roughly about 32 to 33% of patients, and even normal people have only one gene deletion. And then we have another 7 to 9% with 2 gene deletions. So the effect of this on the individuals are not as striking as what you're talking about in thalassemia major. But what we are concerned with in Nigeria is the sickle cell problem, because that's the biggest issue. We are #1 in the whole world with this problem of sickle cell disease. And we have over 4 million people with sickle cell disease. We have a host of the trait carriers are over 40 million people, and these people keep, producing more and more children. And we have very severe sickle cell disease in the country. So the bone marrow transplantation is not something that we can easily reach. It's like it's up there for us. Although the severity of the sickle cell disease is so high that we need to do this. There are many of them who would want to, but they cannot afford it. The environment is not easy for them to get into this. The support from the government is not there. The level of the economic level is not there. So it's nice hearing about this. We know it's available in other places. It could be made available to us. And maybe there is a way in which we can even do some networking on this issue of bone marrow transplantation in regards to sickle cell disease. That's all I would want to say. I'm a PhD. I'm not an MD, but I have contact with a lot of the patients because I was on the bench for some 30 years. And now I have a foundation that's looking after these people. I mean, caring for them as a nonprofit. and I know there are problems, and I have the idea of the science behind these things, but I'm not an MD that takes care of the bone marrow transplantation, but I did my PhD on alpha thalassemia in sickle cell disease, and that was a groundbreaking work in the 70s, 80s. So that's my introduction, and thank you for inviting me.
Thank you so much for joining us. Yeah, it's definitely such a, you know, it's been so interesting for us to see the options available for medical care, you know, throughout the world. And, you know, part of what we're trying to understand, you know, with these kinds of discussions is, you know, obviously, you know, a solution in one country won't necessarily be a solution in the other country. And, you know, how can we help each patient receive the optimum care, you know, in their region? And then how can we develop newer therapies, you know, potentially gene therapy or gene editing that could be, you know, cheaper, faster, more curative, that can be effective and safe. So we all have a lot of homework to do, don't we? Thank you, Dr. Nguyen, for your comment about the about Vietnam. Yeah.
Hi, I don't
Hi.
know if you can see me. Hey, I'm
Yes,
Stephanie Frichalilla from Children's Minnesota. I'm a pediatric hematologist and the medical director of our thalassemia program. We currently have one patient with 4 gene deletion alpha thalassemia that we care for. We have 2 previously transplanted. And then we have a number of hemoglobin H and then hemoglobin H constant spring. So we do have a fairly large Southeast Asian immigrant population that we care for. But I appreciate hearing all of your previous conferences and even now as we're trying to work towards transplant for our patient, but she's struggling with iron overload, and so that's our first task to tackle.
TP Val, I just connected you to Steph so she can be included in future meetings. I think it'll be key.
Thank you so much. Thank you. It's great to meet you, Stephanie. Yeah, were your patients prenatally diagnosed by any chance?
So 2 of the 3 were and received, but late in pregnancy. So they received 1 to 2 transfusions prior to delivery. Our current patient did still have high drops and had a complicated NICU course, but she obviously did well. And the other one, I want to say, had persistent embryonic hemoglobin, which seemed to be sufficient for her, thankfully.
Stephanie, the patients that were transplanted, how old were they when they received their transplant?
One was transplanted shortly after my arrival at our center. I want to say she was about 13, and the other was kind of 9, 10 range. And our current patient is 6. She doesn't have any sibling donors. There was a couple random unrelated donors, but from China, which has, I think, in our experience, been difficult to actually get the units available. So we haven't searched recently just because we have been struggling with her iron overload quite a bit. And a family has a lot of barriers, but I actually just saw her today, and I'm really hopeful they're finally, I think, understanding and really committed to working on the iron management, so chelation.
One of the reports that I showed was from Minnesota many years ago. Scott Baker was there. They published on the 8-month-old with the reduced intensity conditioning, but then that baby needed a second transplant.
Would it make sense, or does it already exist, to publish a series of the stem cell transplants for alpha thalassemia and sort of lessons learned?
I think, Dippy, that's a great thought, because all of these that I compiled are like case reports. And then there is in between maybe one report which has compiled some from before. So And also some of these are older. So now we know more, we know about the conditioning, the regimens, the chimerisms, which should be more lineage specific, not just the whole blood. So I think that's a great thought to put all of this together. Yeah.
Great. And thank you, Anishka, for attending. Yeah. Really exciting to see, you know, the antibody-based conditioning is worked on, is based on Anishka's PhD thesis in Irv Weissman's lab. And it's just so incredible to see that move forward to the clinics with so much success. Really inspiring for bench to bedside research over the course of a career. So. Well, thank you so much, Sandhya, for presenting, and everybody for attending from all over the world. And as I mentioned, this is going to be quarterly, and Val will send out the reminders for the next one, which is going to be on the in utero transfusion protocols. You know, please contact us if you see a patient and you'd like to sort of ask the opinion of the group about your patient, or if you have patients that we could enroll in our registry so that we can have kind of a broader understanding of the trials and tribulations that people go through. And then I guess if anybody wants to work on this postnatal transplantation paper, it seems like that's something that the field needs. Those are some of takeaways from today. Thank you.